Hello, and welcome to today's topic where we're going to be looking at gallstones. So, we're going to begin our discussion by looking at the biliary tract, and this includes its connection to the pancreatic ducts. So, this rather large structure right here, which holds the bile, is known as the gallbladder. And what you'll notice is it has a stalk right over here, which is known as a cystic duct. Now, right above here, we have the common hepatic duct, which combines with the cystic duct to form the common bile duct. And so the common bile duct continues to go down, and then it combines with the pancreatic duct. And once the pancreatic duct and the common bile duct come together, they come out through or the bile comes out through the sphincter of Oddi. Now, just to kind of give you an idea of where the gallbladder is positioned relative to other organs, up here we have the liver. And although this is a very diagrammatic picture, what you'd actually see is that the gallbladder would be tucked under the liver, and you'd only see a small piece of the gallbladder, the belly of it here would show. The stomach wraps around it wraps in front as far as the duodenum part wraps in front of the common bile duct, and then it wraps around, the duodenum, and the sphincter of Oddi enters into the second part of the duodenum. Finally, we also have the pancreas that I'm drawing here in yellow, which is where the common bile duct also goes through. So now let's take a closer look to understand the function of the gallbladder and the pathophysiology of gallstones. So the bile is formed in the liver and it goes down into the gallbladder where you have a standing pool of bile formed. Over time, for reasons we'll go over in a little bit, this can become thicker, forming sludge, or you can actually have the formation of actual stones, which becomes the gallstones that we're discussing in today's topic. So there are three types of gallstones. You have cholesterol gallstones, which I'm mentioning here. We have black gallstones, and we have brown gallstones. By far, the most common type of gallstone is a cholesterol gallstone, which forms this type of yellow stone here. Approximately 85% of all gallstones will be cholesterol gallstones. So how are they formed? Well, they're formed when you have an abnormal ratio between cholesterol and the bile acids in the inside the gallbladder here. So why is it that this ratio, when it's upset, will cause this? Well, here's how to think about it. Here in green, I've drawn all the bile acids, and you can think of the bile acids as surrounding the cholesterol inside. So as long as the cholesterol is inside, it cannot go outside to form complexes with calcium to form the stone. So anytime you have a high level of cholesterol, it overwhelms the bile acids, the cholesterol leaks out, and then it can bind with calcium. On the other hand, if you have a low number of bile acids, there won't be enough to even to contain this cholesterol, and then again, it'll go out to form stones. That's why anytime you have a state of high cholesterol or low bile acids, that can lead to the formation of gallstones. Also, there's something known as biliary stasis. So whenever the gallbladder is not contracting for a prolonged period of time, this structure here can break down, cholesterol can still leak, and then you can form gallstones here. Now, moving on to the black gallstone. So you can see here, this is why it has this name. These stones tend to be very, very black. This is primarily due to increased bilirubin coming to the liver, and then the bilirubin is then converted into bile. Well, what can cause an increase in bilirubin? Primarily, it's any form of hemolysis. So anytime you have any hemolysis, that increases the hemoglobin destruction, and that will increase your bilirubin levels that's coming to the liver. So, what kind of conditions are these? We think primarily here we think of congenital conditions such as sickle cell anemia. We also have hereditary spherocytosis, and of course many others that we could mention. Um, there's also, finally, there's the brown gallstones. Brown gallstones are primarily any sort of infection that affects the gallbladder. So when you think of brown gallstones, you're thinking primarily of E. coli. We have Clonorchis sinensis, which is also known as the Asian liver fluke, and then we have the Ascaris lumbricoides. As you can imagine, these two, the Clonorchis sinensis and Ascaris lumbricoides, is not prevalent in the United States. It's prevalent in many other countries. However, E. coli can transpose from the colon and then go up into the liver, and then get into the sometimes get into the bile duct there. So since the brown and black are not common, we're going to focus primarily on the cholesterol gallstones. That's typically what you're going to be dealing with in the ER or in the ward. So the way I typically like to understand the causes or memorize the causes of cholesterol gallstone is going back to their pathophysiology. So like we discussed, biliary stasis, otherwise understood as the gallbladder not contracting frequent enough to and then eventually your the bile acid cholesterol complex breaks down. The other one is elevated cholesterol, and then finally lower decreased bile acids. So by looking at these three causes and what causes this phenomenons, it's a very helpful way to memorize the causes of cholesterol gallstones. So we'll start first with biliary stasis. So the first thing is age. As you age, the gallbladder just becomes older and it's not contracting as well. So as an individual gets older in age, they tend to have an increased frequency in cholesterol gallstones. Second is estrogen. So in general, what I always found helpful is just remember estrogen is a muscle relaxant. So since it relaxes muscles, that includes the gallbladder, and so anything that any state which will lead to an increase in estrogen will increase the risk of cholesterol gallstones. And of course, the number one risk factor for having elevated estrogen is being a female. So females tend to have gallstones more frequently, and the reason is the elevated estrogen. Specifically, pregnant females, of course, they have elevated estrogen, and females on oral contraceptive pills. So these they will also tend to be at risk for gallstones. Remember, when the purpose of the gallbladder in storing bile is to be contract whenever there is a high level of fat detected in the duodenum. So any type of fasting state, or TPN, which is total parenteral nutrition, this is when a patient is receiving food through IV and nothing per oral for a prolonged period of time. You can imagine the gallbladder won't contract for a prolonged period of time, and then you break down those structures of the cholesterol bile acids, and again you lead to biliary stasis, which causes cholesterol gallstones. And finally, individual with spinal cord injury, the nervous connection to the biliary to the bile to the gallbladder is not formed correctly, and that can lead to formation of gallstones. So the other risk factor we'll look at is cholesterol. So one of the biggest risk factors for elevated cholesterol is obesity. So obese patients are at risk for having gallstones just because of their elevated cholesterol levels. Keep in mind that rapid weight loss leads to breakdown of all sorts of different, fat, uh, proteins, all these types of stuff. And this also includes cholesterol. So this can sometimes increase the cholesterol level in the blood, and that can be translated into elevated cholesterol in the gallbladder and eventually to gallstones. And dyslipidemia, of course, dyslipidemia, elevated cholesterol in the blood just in general can cause gallstones. And finally, keep in mind that diabetes leads to all sort of metabolic derangements, and that is a risk factor for gallstones. Finally, let's look at what decreases the amount of bile acids that you have. Cirrhosis. So again, your liver is not functioning. Your liver is the primary area where bile acids are formed. So you can imagine if you're cirrhotic and your liver doesn't work, you will have a decreased level of bile acids. One interesting connection to make is patients with Crohn's disease are at increased risk of cholesterol gallstones. And this is particularly when it involves the ileal. So Crohn's disease and ileal resection and any other diseases associated with the ileum will affect it will increase the risk of gallstones. And the reason is because in the ileum is where reabsorption of the bile acids occur. And so if you don't have that reabsorption, that'll decrease the amount of bile acids and increase your risk of having gallstones. So now let's try to understand, why would a patient with a gallstone in their gallbladder have symptoms? Of course, if the gallstone is just hanging out here in the gallbladder, these patients are completely asymptomatic. You may be sitting there watching this video, may have a gallstone and you will not know it, and it won't necessarily cause any problems. But what happens with people with symptomatic gallstones is they'll have some type of food particle high in lipid, high in fat, and this food particle will travel down to the duodenum. Once it gets to the duodenum, the body will release hormones to cause contraction of the gallbladder. Because remember, the gallbladder stores the bile, and this bile will help break down the fat particle that's in the duodenum. Now, this, for diagrammatic purposes, I showed direct arrows here, but this typically is not how it works. Typically, it gets secreted into the veins and the blood supply, and then eventually makes its way over to the gallbladder. But just for diagrammatic simplifying purposes, you can think of it this way. And so what happens is these hormones will cause contraction of the gallbladder, and eventually the gallstone gets trapped in the cystic duct. And once it gets trapped here, the patient is no longer asymptomatic. What happens is, as the muscle of the gallbladder is trying to contract, it can't get anything out, and then it starts to, the back pressure will cause a dilation of the gallbladder, and that leads to pain. And this pain is known as biliary colic. So the biliary colic is typically experienced in the right upper quadrant, right here. It extends, just about midway, and sometimes it can be retrosternal and mimic, a typical MI type symptoms. And this extends typically into the back here. Patients can also have, due to referred pain from the nerve fibers, they can have pain right here in the upper shoulder, and that'll come along to the back of the shoulder here, and then, in rare cases, you could even have it in interscapular area. So this pain is typically, the patients will describe, they'll eat something, and then they'll have this pain for about 30 minutes, lasting up anywhere up to 6 hours. This is a very high range, but it can be very highly variable how long the pain lasts. Now, if the patient has uncomplicated gallstones, they'll typically not look ill. They'll have no fever, no tachycardia, and all of their lab work will be completely normal. So if the patient has uncomplicated gallstones, they'll just come in with pain and nothing else, the typical pain they'll have. But keep in mind, these patients are at a high risk for developing complications. So the complication that they can develop is, first and foremost, acute cholecystitis. These patients can develop cholangitis, pancreatitis, and gallstone ileus. Now, one of the reasons why, or actually, one of the things I typically find students get confused about is gallstones and acute cholecystitis. Keep in mind, acute cholecystitis is not synonymous with gallstones. Not every patient with gallstones will have acute cholecystitis. Acute cholecystitis occurs when, due to prolonged lodging of this gallstone, you begin to develop inflammation or even infection around the gallbladder. That's when you have acute cholecystitis. And this is one of the reasons why I wanted to just focus on gallstones in this video and make another video for cholecystitis, so it could be clear in your mind that these are two different processes. Cholangitis is describing infection in anywhere in this duct. And then pancreatitis occurs when this gallstone comes down past the pancreatic duct, and it leads to pancreatitis. It's one of the more common causes of pancreatitis. Finally, gallstone ileus is a very interesting phenomenon. As you can imagine, as this gallbladder continues to contract, you can eventually form a tract between the gallbladder and the duodenum. Now, once you have this kind of fistula formed here, gallstones can then go through there. Now, you may be thinking, well, that's great. You're at least you're getting rid of these gallstones, whether it goes through here or here doesn't really matter. And normally that is an okay thing to occur. However, sometimes the width of this fistula can be pretty large, and you can have large stones go through here. These large stones eventually get into this ileocecal valve and can cause an intestinal obstruction, which is obviously very painful and is a surgical emergency in that sense as well. So typically the first investigation you're going to want to do whenever you suspect gallstones in a patient with a typical biliary colic is a right upper quadrant ultrasound. It's very safe, non-invasive, and there's absolutely no complications from this procedure. So this is very commonly performed. And so here in the left, you can see the outline of the gallbladder here. And what we have inside is biliary sludge. So this isn't necessarily a stone, but it is the bile kind of fluid is much thicker, and this can cause typical symptoms. So this is biliary sludge, and on the right here, you can again see the gallbladder here, and then this little round structure here is your stone. Now, sometimes you can see the structure and it could be a polyp. So how do you differentiate whether this is a polyp or a stone? Well, you see the acoustic shadow here. So because a stone is much thicker, much more dense, when the ultrasound waves come through, they cannot go past it, and so you'll see a shadow here. But if it's a polyp, that's not as dense, and your ultrasound waves will go through normally. Now, one thing I also want to point out is it's also important to look at the walls. Here you can see it's a fairly thin wall with no fluid around it. If you see a thickened wall with fluid, that's more consistent with cholecystitis, and you want to become suspicious of that. Typically, the sensitivity for a right upper quadrant ultrasound is 84%, and the specificity is very well, 99%. So what this means is if you do a right upper quadrant ultrasound, you see the stone, that pretty much clinches your diagnosis. However, if you miss it, well, the sensitivity is 84%, which is okay. There still is a chance that there might be a stone there. So one thing you can do is if if you do the ultrasound and it's negative, um, one thing you can do if your suspicion is still high is just repeat it. And so you can repeat the ultrasound, wait a few weeks, but do it while they're fasting. That'll give you a better image of what's going on. Now, keep in mind that this sensitivity drops to 50 to 60% if the stone is less than 3 millimeters. So, if you get it, get it negative, you do it the first time, it's negative. You do it again while they're fasting, it's negative. And you're still very suspicious, there is a chance that you have a very small stone. In that case, if you get negative twice and you're still very, very suspicious, you can do an endoscopic ultrasound. However, this is something you want to discuss with your patient. Since I brought it up, let's talk about what an endoscopic ultrasound is. So endoscopic ultrasound, it's the same thing as just any endoscopy. They take a scope, they go all the way through the stomach here, and then they park the scope right here, and then here you can see the gallbladder, and then it can detect any stone here. So one of the benefits of an endoscopic ultrasound is first, there's no obstruction to your view. And this can be important in obese patients. Again, obesity is a risk factor. So in obese patients, it can be very difficult to get a visualization of the gallbladder just because of so much subcutaneous tissue and fat involved. Also, remember, because you're looking directly at the gallbladder, you can see some of the much more smaller stones, occult stones, which may be causing these symptoms. Finally, what's also nice about endoscopic ultrasound is you can exclude other causes, such as peptic ulcer disease, gastritis, all these other types of causes, and that's just because as you're going down here to see the gallbladder, well, you can just take, while you're here, you can take a peek around, see what's going on. And also, as we'll discuss in cholecystitis, you can even take a nice look at the common bile duct as it's coming down and even into the pancreas. Now, as you can imagine, this is a little bit more invasive. It's going to require conscious sedation. It's not something you can do in the ER quickly or anything. So you will only do this if you're very highly suspicious, the symptoms are persistent, And if you're going to do an endoscopy to rule out peptic ulcer disease or something else anyways, you could just go ahead and do this as well. So this is one of those times where you really have to weigh the risk and benefits of doing the procedure and also the patient's preference. Typically, these patients present in the ER and they're in a lot of pain. So your first goal is to get their pain under control. Typically, what you want to use are NSAIDs. However, opiates are an option if there's some contraindication to NSAIDs. GI bleed or anything like that, kidney disease, any of those can make you want to use an opioid over an NSAID. So once you've done that, you pretty much have a decision to make. So you have to choose between three options. Either you're going to do emergency surgery, you're going to do an elective surgery, which is surgery after discharge, or you're going to do expectant management. Um, the first one, emergency surgery, the decision is done. You only do that if it's complicated. Since we're talking about gallstones that are uncomplicated, you would never do emergency surgery for an uncomplicated gallstones. And what I mean about emergency surgery is surgery during that specific encounter. So you're going to within the next 12 to 24 hours. Elective surgery is performed as an outpatient. So you'd follow them up with a surgeon, and then they would make an appointment, and they would get a whole workup done. Elective surgeries tend to be less riskier and have less complications than emergency surgeries. This is an option for some patients if they're a candidate, but if they're not a candidate, then of course you're going to do expectant management. That's the only option because they're not a candidate. Now, elective surgery is also required in specific circumstances. If anyone has an adenoma of a gallbladder, well, you have to go in and remove the adenoma, so you might as well just remove the entire gallbladder. Porcelain gallbladder, this is when the gallbladder is very thickened, coarse. That's how it got its name of porcelain. These patients will typically have a high risk of getting cancer, so they get a prophylactic type of surgery anyways. Also, patients with gallstones greater than 3 centimeters, these gallstones are typically very large. They're not going to be removed. So even, there's no such thing as doing expectant management for these patients. They need to get surgery. Expectant management, again, if they're not a candidate, if the patient just doesn't want surgery, they prefer not to have surgery, they can also do expectant management. And so this is, again, one of those circumstances where you discuss with the patients the risk and benefits, and they'll tell you, they can make a decision based off of that information. Also keep in mind that majority of patients will be asymptomatic afterwards. And so that also is one of the reasons why to perform expectant management. And what you can typically tell your patients is the rate of complication of getting risk is anywhere between 2 and 3% per year. So this is the risk that they're taking, that in the future they can develop cholecystitis or any of those complications, and they're going to have to do an emergency surgery anyways. So some patients would say, you know what, I want to take that risk. I might need emergency surgery in the future. While others will say, you know what, let me just get the elective surgery done now, and then I don't have to worry about ever getting an emergency surgery done. So this is kind of the decision that the patient needs to make. You can give ursodeoxycholic acid. That does tend to decrease the risk of complications. So of course, patients going for elective or expectant management, they are going to be discharged. And so it's very important to give them very specific discharge instructions. First, you need to tell them if they have a return of pain and the pain is longer than 4 hours, they need to come back to the hospital. Because when the pain is longer than 4 hours, this is highly suggestive of a complication developing. And so they need to come back, and then we need to take another look at them and their complications. Also, diet. So you need to tell the patient to change their diet. Generally, they want to have a high fiber, high fruit, low fat, in particularly low saturated fats. And what you want to advise them to do is lose weight. And of course, we talk about rapid weight loss becoming a risk factor for gallstones. So they need to make sure that they're not losing more than 1.5 kilos a month. So this is a typical discharge information you want to get them. So this is a discussion on gallstones. Again, I was very focused because I've noticed a lot of students can confuse gallstones with cholecystitis and all of that. So I just want to talk just about gallstones so this topic can be very clear, and then you can move on to other topics. So I hope you enjoyed this discussion, and I'm looking forward to checking you out in my future videos. Thanks.